Assalamu alaikum. Good morning, everyone. Thank you for the organizing committee for the kind invitation, and congratulations on a conference that continues to grow and thrive. It is definitely an honor to be among some distinguished colleagues and experts, and it's a pleasure to be among friends, colleagues, and brothers. So over the next 9 minutes, as per the instructions, I'm hoping that we can go through a journey of how we evolved into complete revascularization after STEMI and what the optimal timing for that should be. So if you look back on the early days in 2004, by the ACC recommendations, it was a class 3 indication that we do non-infarct artery PCI during the intervention and the STEMI presentation. And this is the way we grew up, this is the way I was taught: treat the culprit vessel and walk away. But as we see, transition between 2012 and 2013, complete revascularization has evolved from a class 3 to a class 2A based on some of the studies that we're going to go through. Evolve further into 2021, and we can see that class 1A stage PCI in patients who come with a STEMI, you have to do stage PCI in non-culprit vessels, and 2B is at the time of the primary PCI. So let's see how we evolved into this stage, and we'll go through some of the studies that got us to this point. We'll start off with the PRAMI. PRAMI was a study that randomized patients to complete revascularization after STEMI versus infarct-related artery vessel only. And as you can see here, preventative PCI in a non-infarct-related arteries, staged PCI was discouraged. So this trial showed that recommended that you do index procedure, STEMI, infarct-related, as well as non-culprit versus no preventative PCI. Staged PCI was discouraged, and lo and behold, we see that there is a significant benefit in patients without primary outcome, freedom of events, in favor of preventive PCI. So this was the first indication that departed from initial recommendation of infarct-related only. Now we see that if you do infarct-related as well as non-culprit vessel, you have significant improvement in outcomes in favor of the multi-vessel PCI. And remember, this was index procedure PCI. So culprit came along a few years later, and the culprit trial recommended that at the same setting, but allowed you to have to do this during the index admission. So you don't have to do it during the procedure, but before the patient left the hospital, you had to do the non-culprit vessels. And this allowed you a window of 2 to 3 days during the index admission to do the PCI. And again, we see significant improvement in outcomes in favor of complete revascularization during the index admission. So now we see that there is a consistent signal that treatment of non-infarct-related artery in multi-vessel disease in patients presenting with STEMI does incur positive outcomes. As you can see here, total MACE was statistically significant in favor of complete revascularization for the infarct-related artery. None of the independent endpoints were significant because the numbers were actually fairly small, but the total combined endpoint was statistically significant. The complete trial came along, and along the same lines, and you can see here that this was routine stage PCI. So they evolved from index procedure to now stage PCI, and as soon as possible, but you actually are allowed 45 days to perform this non-culprit PCI. And again, if you look at the numbers, there's significant benefit in angina frequency, treatment satisfaction, quality of life, and this was mostly driven by residual angina. But this opened the door for us to allow a 45-day window to complete revascularization in the non-culprit vessel in patients presenting with STEMI. So, is physiology helpful? There were a couple of trials that looked at FFR-guided. Pre-multi, the NAMI-3, was FFR-guided PCI, and again, the FFR-guided PCI showed significant improvement in outcome as compared to no revascularization. Okay? And again, the FIRE trial showed the same thing. If you do FFR-guided multi-vessel PCI in non-culprit lesions after a STEMI primary PCI, you showed significant improvement in cases of the patients who got complete revascularization. So is it the FFR or is it just the revascularization? And this question was answered by the FLOWER MI. The FLOWER MI randomized patients to FFR guided PCI versus angiography guided PCI, and it turns out that there's no significant difference. So it really matters that you do the PCI and complete revascularization. FFR is helpful to identify these lesions, but angiography guided PCI is equally beneficial. Is the timing different? So we talked about PRAMI in the index procedure. We talked about culprit in the index hospitalization. And then we talked about complete that allowed you 45-day window. Does it matter when you do it? There were a couple of trials actually that looked at this. BioVasc was immediate complete revascularization or 6 weeks out. And it was designed as a non-inferiority trial. And as you can see here, the non-inferiority was met in terms of immediate versus 45 days. And that showed, again, a significant, statistically significant non-inferior analysis in favor of both strategies. Immediate complete revascularization was non-inferior to a stage complete, but what we did see was lower rates of myocardial infarction and unplanned revascularization after the index PCI. Okay? The multi-stars came along, and this was an important trial because, again, it was designed as a non-inferiority trial. But if you look at the outcomes, cumulative incidence of primary endpoint, stage group versus immediate group, significant difference in the outcomes. It met the non-inferiority statistical significance, but also a post hoc analysis of superiority showed that immediate group, early revascularization, did far better than the stage groups, even within a 45-day window. And this was mainly driven by non-fatal myocardial infarction and unplanned ischemia-driven revascularization. So those are the endpoints that actually benefited from doing preventive, early, complete revascularization after primary PCI. So non-fatal myocardial infarction and unplanned ischemia-driven revascularization, higher percentage of patients in this stage multi-vessel, even if it's the first 45 days. And if you go back and you can look at this, the initial difference was within the 45 days, but this persisted to 3 years. So if you look beyond the 45 days, the two graphs are parallel. The most benefit you gain is for the first 45 days with decreased incidence of non-fatal MI and immediate revascularization or need revascularization. Meta-analysis, we'll skip this to stay on time. So I'll leave you again with the updated guidelines in 2021, where staged PCI is a class 1A and immediate PCI is class 2B in patients who present with with STEMI undergoing primary PCI, and this is the PCI of the non-culprit vessel for complete revascularization after STEMI. In conclusion, STEMI cases after successful primary PCI, complete revascularization is recommended. There's data to support immediate, that is the PRAMI, index hospitalization, that is the culprit, within 45 days, complete, and the earlier the better, based on the multi-stars and the BioVasc trial. FFR is helpful in identifying the lesions, but it should not be a deal breaker. Complete revascularization is the indication here. And I stop here, and thank you very much for your attention, and right on time.